Good evening, friends. So now we are going to discuss important topics of psychiatry with the help of mnemonic. Yes. With first question, recently asked question, a 40-year-old male patient come to psychiatry OPD with complaint of repetitive thoughts. Yes, suppose a patient is there having thoughts again and again, my hands are dirty, my hands are dirty, my hands are dirty. Patient want to stop these thoughts but unable to stop these thoughts. And these thoughts are patient's own thought. Patient says that these are my own thought, I want to stop, but unable to stop, develop anxiety. And to relieve anxiety, he wash hand. These thoughts which are coming, those are called obsession. And the ritual, hand washing is called compulsion. So OCD, obsessive compulsive disorder. Yes, in this question they have given his own thoughts, patient want to stop, distressing thoughts are there. Yes, dirty, okay, hands are dirty. So this is OCD, typical case of OCD. But in the same question, if I change only one word or one line, these thoughts has been inserted by somebody else. Inserted, important, inserted by some other person. The answer would be schizophrenia. Okay, the answer would be schizophrenia. Okay, dear friends, let me write here inserted, that is thought insertion. And this obsession or disorder of thought possession, controversial. According to fish psychopathology, it is possession. According to Kaplan, it is content, but I will prefer with possession of thought, mnemonic. Yes, first possession of thought. Yes, possession mnemonic poster. Yes, poster of PK. PK. Yes, again and again, again and again. Whenever obsession, obsessive compulsive and related disorder, again and again, again and again. Okay, obsession, if you pronounce possession, obsession, these two, the ends are same. Okay, now you remember PK. He was alien. So PK, alien, and he used to keep radio do broadcasting. So thought broadcasting, thought alienation include thought broadcasting. I know that is our illogical mnemonic, but you can remember PK, possession, obsession, okay, radio station, broadcasting, and thought withdrawal, thought insertion. If you have seen, yes, PK movie, yes, this, she is thinking that he will insert, but actually he was removing the thoughts. So thought insertion is seen, thought withdrawal, thought broadcasting, all are seen in schizophrenia, and these are first rank symptom of schizophrenia. Important question. According to ICD-10, if any first rank symptom is there, diagnosis is schizophrenia, but DSM-5 has removed this specific significance. So you will remember this PK, possession of thought. Now formal thought disorder. Before this question, wherever you find train, you will remember formal thought disorder. Yes, train, platform of train. Yes, derailment. I know that their description is required, but for the time being, most of the questions are simple single liner. I will discuss important one for the time being. Derailment, loosening of association is loosed. Incoherence, complete loss of organization. You can see all the dabba of train are lost. If you release this association, loosening of association. If this train, yes, derailment. Okay, other than that, neologism, coining of new word whose derivation cannot be explained. Suppose I am a schizophrenic patient, I say this is Tintin Tapa. Yes, this is neologism. You ask me, why are you saying this is Tintin Tapa? I say I don't know, but this is a new name for this pen. This is neologism, characteristic of schizophrenia. A question was asked in Jipmer, coining of new word whose derivation cannot be explained. One question was given, one word was given, that was omni-micro. The answer was, yes, neologism, and it is seen in schizophrenia. So neologism, नई logism, नई bogie. Sometimes in train you will find they add new logi, new bogie. Okay. Okay, Kaustubh Mishra. Yes, dear friends, welcome to the session, and we will remember more and more mnemonic. So train, wherever you find platform, form, formal thought disorder, all formal thought disorder are seen in schizophrenia. Yes, derailment, loosening of association, incoherence. Now neologism. Yes, nei logi, new logi. Okay. Yes, circumstantiality, tangentiality. Circumstantiality, you have seen the toy rotating like this. For the time being, I am making you remember the diagnoses which are included in neologism or phenomena which are included in formal thought disorder, not neologism. Okay, dear friends? Tangentiality, if the train goes towards this, tangentiality. Perseveration, this is rotating, perseveration. What is perseveration? If patient came to me having schizophrenia, I ask, what is your name? Patient says, my name is Mahesh. Where do you live? My name is Mahesh. What is your father's name? My name is Mahesh. The same thought is continued beyond the point of relevance, perseveration, just like this train is rotating. That is perseveration. Thought block. Yes, suppose I am teaching you. Suddenly stops. You ask me, why are not you teaching? I don't give any explanation. That is thought block. Okay? Thought block or train block, whatever you remember these three. Controversial. These three I have included as formal thought disorder seen in schizophrenia, clinical questions. But you will find in few books, you will find that these three are disorder of flow of thought, disorder of stream or flow of thought. I will give you all these PDF, don't worry. Okay. Now I come to this question, formal thought disorder. Which one is formal thought disorder? This is derailment. Obsession is disorder of possession. Somatic delusion. Yes. Thought insertion I will discuss with the questions for the time being. Yes, you know. Neologism is seen in. Yes, all these are recently asked question. Schizophrenia. Very good. Now, please tell me the answer. This is delusion. In this delusion, yes, most important person in the world. Yes, I am the most important person. Delusion of grandiosity. Yes, harm. Yes, family members, neighbors want to harm me. Harm means persecution. So delusion of grandiosity and delusion of persecution, recently asked question in AIMS. Okay. So read question completely. And delusion are disorder of content of thought. Delusion are disorder of content of thought. These are false, firm, unshakable belief. I leave this definition. So let me point out formal thought disorder. You will remember train. Possession, you will remember a PK. Yes. Now content, you know, content, delusion, disorder of content of thought. Stream or flow of thought. I am little bit faster. If you are comfortable, just point it out. Okay. Because I want to cover recently asked question. Most of you have covered these topics in detail. Yes, stream, flow of thought. Yes, stream of thought or flow of thought. Stream, just like stream of water, may be fast or slow. In mania, you are happy. Their stream is increase, and stream is so much increase that there is one word association. One word association. Yes, a question was asked, I love my home, home is sweet home, sugar is sweet, sweet give diabetes, diabetes have sweet urine. Yes, one word association, if you find, that is called flight of idea. That is called flight of idea. Okay, sometimes you will find rhyme. Rhyming, my name is Lily, I live in Delhi, my cat has fat belly, Ali. Speed is increased. And one word association, rhyme method, flight of idea. I do remember one mnemonic. Yes, there was one student, he had written on his car, yes, I am not driving fast, I am flying slowly. So whenever you are driving fast, you will feel you are flying. So if thoughts are coming very fast, that is flight of idea. If thoughts are coming very slow, that is retardation of thinking. In depression, there is retardation of thinking. In mania, there is flight of idea. Yes. Thank you, dear. Now, circumstantiality, thought block, perseveration. I have also included these things in formal thought disorder. This is controversial. So I will discuss, according to me, better to go with formal thought disorder. Now, this is recently asked topic and so many changes are there in this classification. ICD-11. ICD-11. Obsessive compulsive and related disorder, mnemonic is hobby. What is hobby? Anything we do repeatedly again and again when we are free, that is hobby. So in obsessive compulsive and related disorder, you will find one thing is done again and again. Thoughts are coming again and again. OCD, thoughts are coming again and again. Okay. In hoarding disorder, thoughts are coming again and again. Patient will not be able to discard things. Hoarding means to accumulate. To accumulate. Patient is unable to discard because thoughts are coming in mind again and again. If I will discard, it may be used in future. Hypochondriasis according to ICD-11. Yes, I have discussed according to ICD-11. It is OCRD. But ICD-10, it is somatoform disorder. Remember this. Obsessive compulsive disorder, OCD. Olfactory reference syndrome. Yes, thoughts are coming again and again. Patient is thinking that I am having bad smell from my body. I am having bad smell from my breath. That is olfactory reference syndrome. Okay. Body dysmorphic disorder. Patient feel that he is ugly or his nose size is large, small, like that. So body dysmorphic disorder. This is recently asked question. Body focus repetitive behavior disorder. It include excoriation and trichotillomania. Just to make mnemonic, H4 hoarding and hypochondriasis, O4 obsessive compulsive and olfactory reference. Yes, B4 body dysmorphic disorder and body focus repetitive behavior disorder. Okay. In this, I have told you hypochondriasis, ICD-11, OCRD, ICD-10, somatoform disorder. According to ICD-11, trichotillomania. Yes, patient is pulling hair again and again. Patient is pulling hair again and again. Yes. I will take the question of hypochondriasis, don't worry. Okay, dear. Pulling hair again and again. ICD-10. This is impulse control disorder. Impulse control disorder. Okay. But ICD-11, it is OCRD, recently asked question. Which of the following is not classified as OCRD according to ICD-11? Yes, trichotillomania, previously it was impulse control disorder, ICD-11, OCRD. Hypochondriasis, previously ICD-10, it was somatoform disorder, now it is OCRD. PTSD, yes, PTSD is not included in OCRD, answer is C. Okay. Okay, friends. Which of the following type of OCD has poor response to exposure and response prevention? Point it out. Most common obsession is contamination. First question. Second most common is pathological doubt. Yes, I have kept my door opened. That is pathological doubt. So most common, first question. Second. Third point, I will write hoarding symptoms were part of OCD previously. But we found that hoarding is not responding to exposure and response prevention. What I said, exposure and response prevention is treatment of choice of OCD. And we found that hoarding disorder respond very poorly to ERP. That's why it was separated. It was separated and now hoarding disorder is part of OCRD. It is not OCD, now it is OCRD. Got the point? So answer is D. Yes, excessive fear of contamination, repeated checking, simple question, obsessive compulsive disorder, yes, contamination, repeated checking, pathological doubt, OCD. Now, most common symptom associated with adult OCD. This question was asked. In this, they did not give contamination. If contamination is given, the best answer would be contamination. But pathological doubt was given. The second best answer is pathological doubt. Clear? Now, if question is asked and they gave option D, mixed obsession, then the answer would become, yes, mixed obsessions are more common than only contamination. So best answer would be, yes, best answer would be mixed obsession. Remember this point. This question has been asked previously. Got the point? True about OCD, recently asked question in INI-CET, commonly associated with depression. You will find that OCD patient thoughts are coming again and again. Sometimes these are sexual thought towards family member, towards God. Patient want to stop but unable to stop and ultimately will go in depression. You will remember like this. So OCD, most common comorbidity is obsession. And OCPD, obsessive compulsive personality disorder, this question has been asked. Also, most common comorbidity is depression. Both OCD and OCPD, most common comorbidity is depression. The first line treatment of OCD is, SSRI, clomipramine. And atypical antipsychotic are used as augmenting agent, just like risperidone. This question has been asked. Risperidone can be used in OCD as augmenting agent. Prevalence of OCD is 1 to 3%. Contamination is uncommon obsession. Yes, most common. Most common is mixed. After that, contamination. Now, you can easily tell this is controversial. At few places you will find cognitive behavior therapy as the answer. They have given the symptoms of obsession and they ask what is the best treatment. Answer is ERP. A is better than B. Don't get confused by any other reference. Yes, thank you dear Paras. Yes, A is always better than B. Okay, no need to be confused. Best answer is exposure and response prevention. OCD in JIPME 2 times this question has been asked. If you do MRI, you will find bilateral caudate nucleus atrophy. Yes, bilateral caudate nucleus atrophy. A question is asked in OCD, there is in decreased serotonin. At which pathway? Corticostrato-corticothalamic. CST. Corticostrato-corticothalamic. Stratum in physiology you have read. Stratum is made up of caudate and putamen. Yes, stratum is made up of caudate and putamen. Okay. Now, so caudate nucleus atrophy. A patient of bipolar affective disorder on lithium. Whenever lithium question is there, so many points. Yes, first thing, it is narrow therapeutic index. It is having very narrow therapeutic index. Means if serum lithium is 0.8 to 1.2 milli equivalent per liter, then it is therapeutic. If goes beyond 1.5 milli equivalent per liter, this is toxicity. So whenever you prescribe lithium after 5 days, suppose a patient came to me and having lithium, I started on lithium. Suppose I started on lithium, I take from the beginning, I started on lithium. I will ask patient to come after 5 days. How many days? 5 days. I will check the serum lithium after 5 days. Okay, first question, 5 days. I will check serum lithium after 5 days. Now, when you will take the sample after 12 hours of last dose, after 12 hours of last dose. Okay, means suppose he took last dose at 9 p.m. You will take the sample at 9 a.m. Got the point? In lithium toxicity, most important symptom is coarse tremor. Point it out. If fine tremors, that is normal side effect. If coarse tremors, this is toxicity. So suppose a patient is having coarse tremor, you will check reflex, there would be hyperreflexia, ataxia would be there, coma may be there, death may be there. So immediately you will send the patient for serum lithium. If serum lithium is very high, you will do dialysis. Treatment is dialysis. Yes, treatment toxicity. So in this patient there is confusion. The confusion is confusion. Yes, when you find the word confusion, you think delirium. Okay, in this patient clear cut scenario is given about lithium toxicity. So first of all you will check serum lithium. If serum lithium is very high, you will do dialysis. Okay, very good. So all these are previously asked question, nothing new. So most of the question I have covered. It would take around 2 hours, so that each and every question recently asked in 5-6 years will be covered. Severe depression, 3-4 question has been asked. If you find the word severe, means patient may have decreased energy. In severe depression, many times you will find suicidal thought. So if severe depression is there, patient is having suicidal thought, patient, okay, yes, suicidal thought, what you will do? Yes, decrease energy, suicidal thought. Many times you will find that patient want to commit suicide, want to go to market to buy a rope to hang himself, but he is not having energy, so he will not commit suicide. But if you start treatment, patient start having energy. Yes, energy improves. Energy improves. Now suicidal thoughts are still present. Will go to the market, buy the rope, will hang himself. Why I am telling you again and again, hanging is the most common method of suicide. Even now, after so many advancement, the most common method of suicide is hanging. Okay, yes. So whenever you find the word suicide, yes, whenever you find the word suicide, the treatment of choice become ECT. ECT may be direct or indirect. Direct ECT means no general anesthesia, no muscle relaxant. Patient came, you took electricity wire, put here straightening of hair. You must have seen in many movies. That is direct ECT. No, this is not direct ECT. So you should not give direct ECT to any patient according to Mental Health Care Act 2017. Direct ECT is banned. Indirect ECT, you give general anesthesia, patient is unconscious, patient is not aware about the pain which is going to occur in this electric shock. Although electric shock is for milliseconds, but we give general anesthesia and muscle relaxant. Okay, so general anesthesia of choice is methotrexate. But in this question they have given thiopental. But if question is asked what is the anesthesia of choice, GA of choice, methotrexate, muscle relaxant, succinylcholine. So this is anesthetist gave succinylcholine this. What did these agents do to the patient? This is the answer. Very good. Koshtub. Yes friends, I just told you about the depression and severe depression and paradoxical suicide. Before going further, yes, in depression, if you find the word misery, M for misery, M for melancholia, without second thought, misery is severe physical and psychological, yes, suffering, pain. So if a person is old age patient, agitation is there, misery is there, there may be anhedonia, and these patients have increased risk of suicide. Question is asked, suicide is more common in old age. Yes, so melancholia, misery word is sufficient to mark the answer. Melancholia seen in old age, agitation is there. Okay. Paradoxical suicide, I told you, when patient is having severe depression, no energy is there, patient want to commit suicide but is having no energy. When you start treatment, patient finds some energy, go to market, buy rope and hang himself. That is paradoxical suicide, suicide occurring at the time of recovery. Yes, one point, paradoxical suicide is also related to the concept that antidepressant themselves can cause suicidal ideation in adolescent. This question was asked. Okay. Yes. Now, a patient was treated with TCA for severe depression for a week. Which of the following is most important concern while considering his discharge? Please do reply. Yes. First of all, if a person is on TCA, means severe depression, previously there was a concept that if a patient comes with severe depression, we should prefer TCA. Although now we say no, all the antidepressants are having similar effect. But suppose this patient is on TCA. You all know TCA is cardiotoxic. Cardiotoxic. So whenever you want to give TCA, you will monitor the TCA level. What is the best monitoring? What is the best method to monitor the TCA? It is serum TCA or ECG. Yes, ECG is the best for TCA monitoring. But suppose a patient of severe depression in ward is there. I started TCA. I will do cardiac monitoring by ECG. But when I will discharge the patient, I am not concerned about the cardiac effect. Why I am not concerned? Because I will discharge the patient on same TCA. Guideline says that we are concerned, we should repeat ECG whenever we increase the dose of TCA. But at the time of discharge, you will not increase the TCA. So when I am discharging this patient, I am not afraid of arrhythmia of TCA. I will not do ECG. I will do drug. Yes, I am concerned with suicidal risk. I am concerned with suicidal risk because of paradoxical suicide. Paradoxical suicide. This question was asked. They tried to confuse you because it's a very common question of pharmacology that TCA, cardiac arrhythmia, and it should be monitored with the help of ECG. But when you are discharging the patient, I am not concerned about the cardiac side effect of TCA because I know that we should monitor this TCA level by ECG only when I will augment the dose, increase the dose. Okay. Got the point? Thank you, friends. Now, these are questions they are asking again and again. Okay. Patient presented with TCA toxicity. ECG show QRS complex, and whenever QRS complex is 100 millisecond, more than 100 millisecond, yes, the treatment of choice would become sodium bicarbonate. So antidote for TCA toxicity, sodium bicarbonate, and from here you will remember TCA monitored, toxicity is best monitored by ECG. Okay, this is question. Now, this question was asked, this was little bit controversial and really difficult question because they gave the symptom of mania or hypomania. Remember this point, symptom of mania and hypomania are more or less same. The only severity is different. Only severity is different. Mania, hypomania. How you will differentiate? First most important is socio-occupational dysfunction. If patient is having manic symptom, patient came to you having over talkativeness, hyperactivity, increased sexual activity, yes, high energy, decreased need of sleep, pseudo hallucinations are there, yes. Okay, Neha, mania 7 days, hypomania 4 days, very good, but you will remember the duration in the last. First and most important differentiating point is socio-occupational dysfunction. If present mania, yes, hypomania. Second, if you find any psychotic symptom, yes, psychotic symptom, without second thought, the answer would be mania. If there is hospitalization, without second thought, the answer would be mania. In hypomania, no psychotic symptom, no hospitalization. Now I will think of 7 days and 4 days. Okay. Pseudo hallucination absent. One more. In mania, there is flight of idea. Here there is prolixity. There is prolixity. Okay, friends. So you will remember the sequence, because this question was very difficult question, because pseudo hallucination is not given in the criteria of DSM or ICD. But ICD has described that pseudo hallucination are more frequently associated with mania rather than hypomania. Got the point? So in this question, yes, I will differentiate between mania and hypomania by pseudo hallucination. If pseudo hallucination is not given in the question, it becomes very difficult to solve. But they gave pseudo hallucination. Got the point? Now, bipolar. Bipolar affective disorder. This is recent concept. Okay, ICD-11, BPAD-1 and BPAD-2. Bipolar affective disorder 1 and 2. 1. You will remember, in any question, if you find mania, without second thought, you will mark the answer BPAD-1. Mnemonic. 1. Male-female ratio is 1. Means equal in male and female. Yes, prevalence is 1%. Around 1%. Suicide rate, mnemonic, around 10%. Okay, 5 to 15%. Okay, 5 to 15%. Okay, these are BPAD-1. BPAD-2 more common in female than male. Clear? In BPAD-2 there is hypomania. Okay. Yes. Let me describe in a different way. Yes, suppose there is a patient came to me having depression. Depression is represented like this. Patient came to me having depression. I will say this is unipolar depression. Now, this patient should be given antidepressant. Question is asked, antidepressants are chosen on the basis of side effect profile. This is question, are chosen on the basis of side effect profile, old concept. Now we say are chosen partly. I take different color, partly. Latest edition of synopsis writes that antidepressants are chosen partly on side effect profile. I will tell you, I explain. Suppose a patient came to you, depressive criteria is fulfilled, and this is unipolar depression. Now this patient came you again depression. You will say more than one episode of depression, recurrent depressive disorder. Here the diagnosis is recurrent depressive disorder. You took history properly and you found that every time this depression is occurring in winters, every time in winters, the diagnosis would become, yes, please do comment. Depression is occurring in a particular season, seasonal affective disorder. A question in ICD-11, it is clearly written, latest. Yes, ICD-11, it is clearly written that if seasonal affective disorder occurring every time in winter, but the cause is not winter, cause is stressor, just like loss of job, then the answer would not be seasonal affective disorder. The answer or diagnosis would be recurrent depressive disorder. Important point. Yes. So question is asked, patient is having again and again depression, and this depression is occurring in winter because there is loss of job, factory is closed in winter, then the answer would not be seasonal affective disorder. Answer would be recurrent depressive disorder. Got the point? And seasonal affective disorder, the treatment of choice is, yes, phototherapy or bright light therapy. Bright light therapy. Question. Now, if this patient If this patient develop hypomania, yes, if this patient develop, let me take another page. If this patient develop, yes, hypomania, yes, I remove this, hypomania. Now the diagnosis would be, please do comment. Yes, please do comment. Yes, कमरे के पर्दे खोल सकते हो. Yes, you can do. Yes, you should remain in more and more light. That's the reason that sometimes bright light when we are studying. Yes, this is very important. कमरे के पर्दे खोलो. It's very important when you are studying the last phase of preparation. Be positive. Yes, your room should be very lighted. Okay, not at the time of sleep, but before that. Okay, BP, AD 2, type 2. If mania is there, then BPAD 1. देख रहा है विनोद कैसे डायग्नोसिस चेंज हो रही है, हाउ डायग्नोसिस इज बीइंग चेंज्ड. ओके, same patient. Now this patient developed depression. Now this patient developed depression. This is called bipolar depression. Very, very important. Bipolar depression. Never give antidepressant alone. In bipolar depression, never give antidepressant alone. Why we are not giving antidepressant alone? Suppose this patient, you are sitting in OPD, you are feeling the consultant feeling just like sitting on the chair of consultant, and a patient came to you having depressive symptom, criteria of depression fulfilled. You did not take the history, past history, okay, and you thought this is simple depression, unipolar depression. You started antidepressant. Always take past history. If previously mania or hypomania is there, then it is bipolar depression, and you gave, suppose, antidepressant. Suppose you gave antidepressant. After 2 days, 3 days, 4 days, 5 days, patient came to OPD having very happiness. Now he developed mania. This concept is, or this phenomena is called switching. So if patient, this is very, very confusing and controversial question. What is the treatment of switching? First of all, tell me who caused switching? Who caused switching? Antidepressant. So stop antidepressant. First priority would be, if patient came to me, I will stop antidepressant. Then I will treat the patient according to mania. So if question is asked, stop antidepressant, mood stabilizer, I will prefer to mark stop antidepressant first. That is the reason at few places you will find that they means few consultant never give long acting antidepressant. Why? Suppose bipolar depression is there and you gave long acting antidepressant, even if you stop, the effect of antidepressant will persist. That is the reason, yes, we never give long-acting antidepressant if we are suspecting that this patient may go into bipolar disorder. Got the point? Very good. Neha, Pulkit, yes. Spurthi. So this is frequently asked topic. Next question, this question was asked. If male patient history of depression came to OPD, was prescribed imipramine. Imipramine is antidepressant. Yes. Excessive talk, increase activity, means patient has switched to mania. So what you will do? Yes, stop the current antidepressant and start mood stabilizer. Okay. Got the point? Yes, why not antipsychotic? Although antipsychotic has mood stabilizing property, but we will see the profile, patient profile, and will decide. Okay. Yes, once mania, always mania. Yes, I told you, if mania is there, without second thought, the answer would be, if mania is there without second thought, yes, answer would be BPAD 1. Yeah, let me give you a question was asked. They gave mania. Yes, I told you earlier, depression, recurrent depressive disorder. Mania. Diagnosis is recurrent manic disorder. Option A. Option B, BPAD 1. What is the answer? Please do comment. What is the answer? If again and again mania, what is the answer? Yes, BPAD1, no such diagnosis. Recurrent manic disorder is no diagnosis in classificatory system. Okay, neither ICD nor DSM. Very good. Yes, all of the following statements are true regarding bipolar disorder except BPAD1 has equal prevalence, 1 is equal to 1. Okay, bipolar 2 more common in females, true. 5 to 10% suicide completion, 5 to 15 around, true. More common in age group 35 to 45, no, this is second decade, means adolescent and young adult. Yes, adolescent and young adult, because many times you will find confusion between BPAD, bipolar and schizophrenia, because schizophrenia also occur in second, third decade, second or third decade, and BPAD also occur in second and third decade. How you differentiate schizophrenia? You tell me, schizophrenia, BPAD. Yes, BPAD is having episodic course. Yes, schizophrenia is having, yes, continuous course. Correct? Do you agree? For the time being, I do agree, you do agree, but according to ICD-11, schizophrenia is having episodic course. A question was asked, yes, episodic illness with complete inter-episodic recovery. According to ICD-11, I have modified the question. Okay, episodic illness with complete inter-episodic recovery according to ICD-11. Option A, BPAD. Option B, schizophrenia. Option C, both. Please do reply. Please do reply. Yes. Yes, please. Note C, BPAD. Yes, that's why I'm saying that ICD-11 is really important for question purpose. If you are thinking about, INI-CET and this exam also, we can't ignore. Okay. Schizophrenia in ICD-11, it is clearly written that in episodic illness of schizophrenia, complete recovery may not occur. Okay, means few symptoms may remain. Yes, complete recovery means episodic course with complete inter-episodic period. Yes, period is only and only BPAD. Got the point? Okay, friends, do comment. Yes, we have covered. Yes, at this time I was little bit different from the previous discussion I used to do. I tried to cover more and more question which has been asked previously, okay, in any exam. Yes, if a patient came to me, yes, I will write here. Yes, ICD updates I have taken care, which are important, which can be asked in your exam. Okay, one important update I found about this. Yes, this is important because episodic course they have given even in schizophrenia, but there is no complete inter-episodic recovery in many cases. Okay, clear, friends? Now, yes, depression, EMI gaps cause depression. Yes, I will give stress at this point. EMI gaps cause depression. Yes. E for energy, M for mood, yes, I for interest. Gap, G for guilt, appetite, psychomotor activity, sleep, suicide, concentration. These are 9 symptoms according to DSM-5. Yes, G for guilt, A for appetite, P for psychomotor activity, S for sleep, yes, or suicide, and C for concentration. C for concentration. According to DSM-5, out of these, if 5 symptoms are there for 2 weeks, 5 symptoms are there for 2 weeks, diagnosis is depression. You can't afford to forget this number 5. DSM-5, 5, depression. If a patient came to me having depressive symptom but not fulfill the criteria of depression, suppose he's having only 2 symptom, 3 symptom, 4 symptom, diagnostic criteria is not fulfilled, these symptoms are there for 2 years. For how many years? 2 years. I will say 2 years. This is dysthymia. Dysthymia. Previously type D personality. Okay. Yes. Now this patient came to me. I made the diagnosis of dysthymia. Now this patient again came to me after 3 year, 4 year, and now he is having more depressive symptom. Total 5 symptoms are there. Diagnosis is depression. So you will say this is depression in dysthymic patient. Means 2 types of depression and dysthymia. Depression in dysthymic patient is called double depression. Got the point? Yes. So let me solve this question. IT employee, yes, has guilt, hopeless, not able to concentrate on work. His symptoms start 3 years back when he entered the college. Likely diagnosis is, okay. So better answer would be dysthymia. The answer would be dysthymia. Ames 17. Double depression is depression in dysthymic patient. Clear? Yes, most of the question I have covered. A 20-year-old mother was diagnosed with mild depression. Depression may be mild, moderate and severe. In any patient, if severe depression is there, you will think of suicide. Point it out. If suicide word is there, without second thought, severe depression. If psychotic symptoms are there, yes, then yes, I will reply you. Yes, psychotic symptoms are there. According to ICD-10, it is severe depression. Yes, ICD-10, severe depression. If ICD-11, this is recent update. In ICD-11, it is said that psychotic symptom may be present. In moderate and severe depression. Point it out. ICD-10, psychotic symptom only in severe depression. ICD-11, psychotic symptom may present in moderate and severe depression. Got the point? Now, yes, one doubt. Why not? Yes, in this they have not given adjustment disorder, okay, but adjustment disorder start after stressor. Yes, within 3 months, within 1 month, different criteria, and these symptoms resolve usually within 6 months after stressor is removed. Within how many months? Yes, within 6 months after stressor is lost, means these symptoms started. Yes, when he was in college, these symptoms are not only in employment, okay, these symptoms are continuous. Yes, very good. So Ujjwal, got the point? Now adjustment disorder I will discuss, don't worry. Yes, in this answer is mild depression. If a patient came to me having mild depression, I will do cognitive behavior therapy. So in this they have given that child is 3-month-old and means she is lactating. So in lactating mother we will not give SSRI, we will avoid, if can be avoided. CBT is better. Yes, in this patient, even if lactating mother is not there, if mild depressive patient came to me, I will start with CBT plus exercise. What I said, CBT, yes, plus exercise. Okay, clear? Yes, postpartum blues are not depression. I will discuss that part. postpartum depression may be there, but postpartum blue are not under depression, because postpartum blue, it is a transient. In postpartum blues we give psychoeducation and supportive therapy, patient recover, no need of cognitive behavior therapy. Okay, yes. Severe depression with least side effect, SSRI is having least side effect. Yes. Now, other side effect of SSRI, nausea is side effect, vivid dream is side effect, anorgasmia is side effect, siluria is not a side effect, Escitalopram is SSRI. Yes. Anorgasmia, decrease libido. This question has been asked. Decrease libido. So whenever you will find a patient of depression or any other psychiatric disorder in which you are thinking to prescribe SSRI and sexual problem is there, sexual dysfunction is there, you will never give SSRI. In this depressive patient, suppose a depressive patient is there, came to you having erectile dysfunction, you can't give SSRI, you can't give SNRI, you will prefer to give, yes, mirtazapine. Recently asked question, first question. Second, bupropion question. Third, agomelatine. Yes, siluria is common side effect of, yes, wet pillow syndrome, very good. Yes, so agomelatine is also not having sexual side effect. Okay, it is commonly seen with clozapine. If clozapine, I will point out, it is having anti-suicidal property. Another drug, lithium, is also having anti-suicidal property. Both question has been asked. Okay. Yes, according to latest NICE guidelines, they have given 3. Yes, you can't select one out of these 3. All are having no sexual side effect according to data. Okay, but most of time you will find the question on bupropion. Recently INI-CET they asked mirtazapine. They have not asked this, they can. Now, middle-aged person, the simple question was they asked serotonin norepinephrine reuptake inhibitor, SNRI. Yes, you all know in depression there is decreased serotonin, decreased norepinephrine, decreased dopamine. Yes, you will remember the sequence, because one question was asked that which of the following combination is decreased. Option A, serotonin and norepinephrine. Option B, norepinephrine and dopamine. The best answer was which are decreased. Yes, serotonin, norepinephrine. Now you will make a mnemonic. Yes, if I write V, venlafaxine means first 2 reuptake inhibitor. Yes, serotonin, norepinephrine. Desvenlafaxine, duloxetine. Do matlab duo, 2. Okay, so you can remember venlafaxine. Okay, this is SSRI. Yes, atypical depression, you will find a son is there, father is very much disturbed that he is sleeping the whole day. Normally in depression sleep is decreased, but in this boy is sleeping the whole day. He is eating large, but in depression appetite is decreased. Yes, in atypical depression patient is having reversal of biological function, means he will eat large amount, he will have increased appetite, increased sleep. 1 point. Second point, he is having, yes, he is having response to stimulus, means he is very sad throughout the day. Suppose his girlfriend call him, yes, he becomes happy, means reactivity of mood is present. And his father said do that work, he would say no papa, no, I am feeling paralyzed, I am feeling my limb very heavy. That is called leaden paralysis. Marked fatigue, heaviness in body, this is called leaden paralysis. This is increased sleep and weight. Yes, variable mood responding to positive stimulus to surrounding. Yes, this is present. TCA are better? No. MAO and SSRI are better than TCA. Yes. Clear? So venlafaxine is SNRI. Yes, Madhavan. So atypical depression, you know that everything is atypical. Sometimes you will feel the patient is doing telling lie. Patient is telling lie. That's why atypical depression is also called hysteroid dysphoria. Okay, just like hysteria. Okay. Now, classical symptom of depression: early morning insomnia, early morning awakening, or terminal insomnia. 2 hours prior to normal awakening time. Prior to normal awakening time. Okay. Second point, there is reduced latency of REM sleep. Reduced latency of REM sleep. Okay. Reduced latency of REM sleep. What does it mean? Suppose this is sleep. This is NREM sleep. This is REM sleep. Normally REM sleep comes after 90 minutes. Normally REM sleep comes after how many minutes? 90 minutes. Okay, but in this REM sleep will appear early. When it will appear early, sorry, let me draw it again. It will appear early, yes. What will happen? This deep part of NREM sleep will be lost. This deep part will be lost. Okay, so deep sleep. Deep sleep is also called slow wave sleep. Slow wave sleep. Okay, this deep part is lost. Deep sleep is having delta waves. Delta waves. Mnemonic 3D. 3D movie. So hertz, 1 to 3 hertz. That's why it is also slow wave. So deep part of sleep is lost in depression by reduced latency of REM sleep. Many times you will find the patient is in depression, will come to you, Dr. Saab, previously I used to take a sleep of 8 hours. Even now, Dr. Saab, I am taking sleep of 8 hours, but I don't feel fresh in the morning. What is the reason? Because deep sleep part is lost because reduced latency of REM sleep. Got the point? Both are questions: terminal insomnia and reduced latency of REM sleep. Defense mechanism in depression is introjection. Mug it up. Once this question was asked long time back. Displacement is seen in, yes, phobia. Okay. Projection, psychosis. Yes. Delusion and, yes, hallucination, projection is there. Altruism is mature defense mechanism. Mature defense mechanism. So introjection in depression. Note true regarding delusional disorder. Delusion is false, firm, unshakable belief. It takes time to develop. Means it will not occur in early age. It is occurring in middle age. Delusional disorder usually occur. Yes, delusional disorder occur in middle age. Middle age. Clear? So sensory impairment, yes, if sensory impairment is there, you will find the patient is not hearing the thing what family members are talking. Sometimes he start feeling delusional ideas. Early immigration, at new places he will feel that something is being commented and doing differently according to him. Social isolation, these can be the predisposing factor for delusional disorder. Got the point? It is occur at early age? No, it occur in, yes, middle age. This question was asked. Schizophrenia 4A, yes, very important topic. Schizophrenia, Bleuler's 4A. Autism, yes, is part of 4A. Automatism is seen in complex partial seizure. Complex partial seizure, not a part of 4A. Loosening of association, ambivalence, affective disturbance. Very good. Answer is B. Automatism is not feature of 4A given by Bloller. Good prognostic factor in schizophrenia accept. Please do comment. Yes, positive symptoms are good. Negative symptoms are poor prognostic factor. Late onset is good prognostic factor. Early onset is poor prognostic factor. Insidious onset is poor prognostic factor. Acute is good. Acute is good. Thank you, sir. Ashwani sir. Thank you. Associated with depression. Associated with depression. Yes, it is good prognostic factor. If depression is there, mood fluctuations are there, depressive symptoms, so affective disorder, family history, then it is good prognostic factor. Recent update pointed out developed country. Yes, it is good or poor? Good or poor? Please do comment. Developed country is a good prognostic factor. Yes, or poor prognostic factor? Yes, Dr. Ashwani is here. He is a very good friend, and anatomy, I have learned anatomy from Dr. Ashwani. Yes, when I was preparing second time. Yes, I saw his video, really nice videos. Okay. Yes, developed country, good prognostic factor. Yes, please do comment. Yes, good prognostic factor. Previously, it was considered poor prognosis, but latest edition of synopsis, these are good prognostic factor. Yes. Negative symptoms of schizophrenia are all except. Yes, negative symptom. Yes, overactivity is a positive symptom. Okay, anhedonia, alogia, apathy, amotivation, these are negative symptoms of schizophrenia, and they have poor prognosis. Yes, poor prognosis. Yes, a psychotic patient develop voluntary purposeless movement, vexy flexibility. Yes, catatonia, you will find separate diagnosis according to ICD-11 question. Potential question, DSM-5 and ICD-11 catatonia is a separate diagnosis. We found that catatonia is having vexy flexibility, posturing, negativism. It can occur in any psychiatric disorder, means not only in schizophrenia. Catatonia may occur in any psychiatric disorder. Suppose a patient of catatonia comes to me, I will immediately put ECT. No. I will try to treat the patient by injection lorazepam. Many times we found that, yes, injection lorazepam, patient may improve. If not improving by lorazepam, yes, if question is asked initial management, then answer is lorazepam. If question is asked treatment of choice of catatonia, then answer would be ECT, modified ECT. Yes, hebephrenic schizophrenia. Yes, some types of schizophrenia removed in ICD-11. Very good, ICD-11 and DSM-5. Even now question is asked that hebephrenic schizophrenia is having poor prognosis. Hebephrenic is also called disorganized schizophrenia. Formal thought disorders are there, disorganized schizophrenia, hebephrenic schizophrenia, formal thought disorders are there. Yes, disorganized behavior is there. They are early onset, means young girl, yes, looking at mirror, silly smile, she is smiling, adolescent girl looking at the mirror and smiling. You will say, sir, we also smiled at our adolescent age. but you are, yes, smiling and you are looking at the mirror with purpose. But these hebephrenic patients are standing in front of mirror without any reason. Yes, that is, yes, flat affect, disorganized, yes, behavior. This is hebephrenic, poor prognosis. Old classification, nowadays classificatory system, types, subtype of schizophrenia is removed. Okay. So these are, I think, one doubt, catalepsy and cataplexy. Catalepsy. Cataplexy. Cataplexy is seen in narcolepsy. लेप्सी में लेप्सी नहीं होती. लेप्सी is not seen in लेप्सी. Leprosy is not seen in leprosy. Okay, what is catalepsy? If a patient is maintaining abnormal posture, this is lap. This is lap. Catalepsy is abnormal posture like this for hours. Yes, catalepsy. Cataplexy, sudden loss of muscle tone. Sudden loss of muscle tone, that is cataplexy seen in narcolepsy. Question: cataplexy, no loss of consciousness. No loss of consciousness. Important question. No loss of consciousness. Okay. Now, in this patient, 36-year-old man, yes, financial loss. Point it out. There is financial loss. Yes, after that, yes, fearful that somebody wants to harm him. Yes, somebody wants to harm him means delusion. He could not sleep or eat properly, began to hear voices of female, hallucination. So delusion and hallucinations are there, and his symptoms stopped after approximately 1 week. Means if symptoms stops within 1 month, then it is ATPD or brief psychotic disorder. According to ICD-11, this is ATPD. According to DSM-5, this is brief psychotic disorder. Okay. So this is clear cut. It is not schizoaffective because the schizophrenic symptoms criteria not fulfilled, affective symptoms criteria not fulfilled, duration is very less. If these symptoms, yes, sleep, eating, these are not symptoms of depression at all. Yes, being fearful, yes, fearful is not a part of depression. So in this, schizoaffective is not there. Okay, dear friends, brief psychotic disorder, remember this point, ATPD in ICD-11, and in this you will find that patient is not having typical, yes, ICD-11 says that ATPD usually after stressor, okay. DSM-5, we found brief psychotic disorder, stressor is not required. In this also not required, but usually after stressor, just like fever. And in this there is pleomorphic picture. Means symptoms are changing day by day. Symptoms are changing day by day, hours to hours. Yes, means content of delusion is changing. That is brief psychotic disorder. Chronic schizophrenia, there is medial temporal atrophy, then frontal lobe, then yes, frontal lobe. So this is question has been asked. So both are there, but better answer is medial temporal lobe. First rank symptom, yes, you all know, thought insertion, thought withdrawal, thought broadcasting. These are first rank symptoms. Somatic passivity, what are the first rank symptoms? Yes, thought insertion, thought withdrawal, thought broadcasting. They are 11 in number. How many? 11. Yes. Made impulse, made volition, made affect, somatic passivity. These are first rank symptom, and these are seen in schizophrenia. Which of the following is first rank symptom? Yes, made affect. What is made affect? Suppose a schizophrenic patient, yes, this clinical question is asked sometimes in MLE pattern. Yes, suppose a patient is of having schizophrenia, is sitting in the corner and is smiling. It is normal or abnormal? Please do comment. Yes, a schizophrenic patient is sitting in the corner and smiling. Normal or abnormal? It is. It may be normal. Yes, he is remembering his girlfriend, good days of his, and he is smiling. You ask the patient, why are you smiling? And patient said, Doctor Saab, I am not smiling. Somebody is making me smile. That is made affect. That is schizophrenia. Yes, it is the explanation of patient which will determine the phenomena. If patient says that somebody is making me smile, that is made affect, first rank symptom. G-track technique, okay. G-track technique, we found that it is used for administration of long-acting depot antipsychotic. Yes, yes, if you pull the muscle fold, inject, and when you remove, yes, you relieve the fold. The pathway is zigzag. Why we are using G-track technique? Because if you inject directly and remove, some amount of drug will be oozed out, wasted. That's why we use G-track technique. So before ending, yes, most of the recently asked question I have tried to cover. Now I am going to end. Before that, I will try to motivate you in the sense that whatever hard work you have done, it will be paid. Trust me, dear friends, in this phase you will have so many anxiety. Yes, FOMO is quite common. Yes, I have left something, I can't recall the other person is knowing much more. But it's not the matter of knowing things, it is the confidence which will determine your success. Okay, so be confident in any situation. Yes, don't lose your hope. Till last you will study, you will not stop till last. Okay, if you will continue till last, trust me, you will clear your exam with the desired rank. Thank you, friends. Best of luck. Take care. We'll meet soon. We'll remain connected. Thank you.